This is Selma Schimmel in Chicago for the group room. We're at the 2012 Multidisciplinary Symposium in Thoracic Oncology, which is brought to you by ASTRO, IASLC, ASCO, and the University of Chicago. And I'm so happy to be joined by Dr. Joan Schiller, Chief of Hematology and Oncology at the University of Texas Southwestern Medical Center in Dallas. You're also the president of the National Lung Cancer Partnership.
I am, thank you.
I want to start with what your talk has been here at the symposium, Advances in Chemotherapy for Non-Small Cell Lung Cancer.
So what I talked about this morning was the fact that we have come a long way when it comes to chemotherapy, and I tried to put a perspective on where we were then and where we are now. And I showed some clinical studies that had been done in the 80s in which patients were randomized to chemotherapy or no chemotherapy. What these studies showed was that the patients who got randomized to receive chemotherapy had a better survival than those who did not get chemotherapy at all. And it's amazing. There were 5 or 6 of those types of randomized studies done, chemo versus no chemo. When you think about it, there haven't been 5 or 6 randomized studies done in breast cancer patients of chemo versus no chemo. We would never put up with that. Or colon cancer patients, we would never put up with that. But we put up with it for lung cancer, believe it or not. And sure enough, proved that chemotherapy, even that very tough chemotherapy, could prolong survival in lung cancer patients. Not by a lot, but enough to show that chemotherapy could impact the natural history of the disease. And since then, since the 80s, when we finally showed that yes, chemotherapy can work, we spent a lot of time trying to define or refine exactly how to give that chemotherapy. So we did a number of studies which looked at how many drugs one should give, 1 drug versus 2 drugs, or a doublet, like we like to say, and showed that 2 drugs works better than 1. We looked to see is 3 drugs better than 2 and determined that was not the case. We looked to see whether one of those drugs had to be carboplatin or cisplatin and found out that by and large it probably doesn't matter which of the 2. And we even asked whether or not you really needed the carboplatin or the cisplatin and found out probably didn't need that either. But then we also started to bring in new drugs into the equation. And when these drugs are used properly, they really are starting to move the needle. Again, not a real lot, but again, another step forward. So that with the new chemotherapy regimens we have these days, we are now seeing people live out 2 years or longer.
Would you say that with the addition of targeted therapies for lung cancer, that chemotherapy still remains the cornerstone of treatment?
I would. So targeted therapies, as you know, refers to drugs that target pathways that are specifically found in cancer cells. So because these molecular pathways or these molecular reactions don't happen in normal cells, these drugs don't hit normal cells very much. That's different than chemotherapy. So chemotherapy works kind of indiscriminately against both normal and cancer cells, and therefore has more side effects. So targeted therapies, I think, is one of our major steps forward. Many of those drugs are oral because they target certain pathways or certain molecular reactions within the cancer cell. They only target those cells that have those molecular reactions, so they're also much more specific. But having said that, nonetheless, not every cancer cell has that particular pathway or that particular molecular cascade, so I think we're going to end up using both chemotherapy as well as targeted therapies.
Thank you, Dr. Joan Schiller, Chief of Hematology and Oncology at the University of Texas Southwestern Medical Center in Dallas, and President of the National Lung Cancer Partnership.
And thank you very much. Thank you, Selma.